Please start. We are live.
A very good evening to everyone. It's with a great pleasure we welcome you all for this very exciting and insightful session on the emerging immunotherapeutic in non-small cell lung cancer. This is done under the aegis of Cancer Research and Statistic Foundation, and Cadila Pharmaceuticals is the academic partners. Without wasting time, I have a pleasure to welcome Mr. Rajiv Saxena, who is the Vice President with Cadila Pharmaceutical, to set the ball rolling. Over to you, Rajiv, for your opening remarks.
Thank you very much, Tarun. Thank you very much. You're a dear friend and kind man. Thank you very much for helping us organize this great program. Live webinar on an emerging immunotherapy in NSCLC. And I hope I didn't say anything. It is really my privilege to have this eminent galaxy of doctors gathered today here on this very platform on lung cancer. And none other than, Dr. Advani himself gracing the occasion today, coming in at right in time, 6 p.m. when we started. It's huge privilege for me to really have this program. And Dr. Vaid, the chairperson, both of today joining in time and then helping us to take this further, sir. And I'm really grateful to Dr. Kumar Pravash, already conceptualizing and then taking forward. I would be doing small things, sir, if I don't introduce Dr. Advani, though he does not require any kind of introduction, but I would be failing in my duty if I don't say a few words in his honor. Dr. Advani is chairperson today, and we all know that he is been rewarded by the highest civilian award in this country, namely Padma Bhushan Award 2012 and Padma Shri Award by Government of India in 2002. He is also recipient of Dhanvantri Award in 2002, a BC Roy National Award by Medical Council of India in 2005, Rashtriya Krantivir Award from Ujjain in 2014, and awarded Lifetime Achievement in Oncology by Harvard Medical International in 2005. Dr. Advani was part of multiple clinical trials, national, international, to have many cancer patients, especially children with lymphoblastic leukemia, was the concluded was 1,200 patients, the largest size. Member of various societies, ISO, ISMPOs, ESCOs, you name the society, he is always member and then key partner to this. He holds expertise in lymphoma, bone marrow transplant, acute leukemia, multiple myeloma, breast cancer, and he's a teacher to medical oncology fraternity in India. So I welcome Dr. Advani and request him to say his remarks.
Thank you, Rajiv. I think on my behalf, as well as my behalf of my co-chair, Dr. Ashok Vaid, I would like to, first of all, thank the organizers for giving us this opportunity to introduce the subject. And I think the immunotherapy in cancer today really does not need the introduction. It is not the old immunotherapy, which we were trying for last 30 years. It's a new approach. And this new approach has come up basically because of the better understanding of the sequence of the immune reaction in the body. And based on this, we have been able to identify various molecules which are responsible for inhibiting the immune response. And this is what we call it checkpoint inhibitors. So what the scientists have developed is the checkpoint inhibitors. And if you introduce these checkpoint inhibitors, obviously the immune reaction will get more amplified and ultimately able to eliminate the tumor cells. And what we have found is phenomenal changes. And today, the immunotherapy after the chemotherapy and the targeted therapy has become a very standard treatment in many of the diseases where previously we did not have really any much. And that's why we are all collected here, and we will be really discussing the various aspects of the immunotherapy, particularly with reference to the lung cancer. So I think without wasting much time, I would request the organizers to proceed with the other speakers.
Thank you, sir.
Ashok, Vaid, you want to say?
Sir, thank you very much. And before Dr.
Sir,
Vaid says something, it would be my again privilege, and
Yeah.
I will be feeling if I don't introduce him to audience, though he does not require any kind of a introduction, sir. I understand that. Dr. Vaid is a Padma Shri oncologist amongst us. I've done a lot of clinical trial to his name. He is today chairman and director at Medanta Institute at we all know that he is one of the uh, doctor who have more than 40 international and national studies in clinical research in medical oncology and hematology. So it is really, really privileged to have him over here coming out from Jammu and establishing different milestones in oncology. To Dr. Vaid, please.
Thank you, Rajiv, for those kind words. I don't have much to say, and Dr. Advani has already set the context. All that I have to say is a big thank you to you, your organization, to Kumar Prabhash, and for bringing up this very interesting topic. And last but not the least, it's always an honor and a privilege to be co-chairing with your own teacher. Dr. Advani has been my teacher, and it's a very proud moment and a very privileged moment for me to, sir, to be in your company and to be co-chairing this session. Thank you so much. Back to you, Rajiv.
So kind of you, sir, for your kind words. It is really encouraging for me, and then these things only, sir, gives me always this push. I have still do much better, and thank you very much for coming and passing this remark. Thanks a lot, sir. We do have with us Dr. Shyam Agarwal. Dr. Shyam Agarwal, again, as one of the chairperson for the program, we invited, and thank you very much, Dr. Shyam Agarwal, for accepting this invite. And I would be again saying few words for Dr. Shyam, though he is a great oncologist India has ever produced, but to name his few things which we would like to just say. Present chairman and HOD department as medical oncologist, Sir Gangaram Hospital, New Delhi. He is done extensive training in India and overseas over various issues pertaining to cancer treatments. A member of various societies, ESCO, ISMO, EHS, and ISMPO. He has done a lot of good work in ISO, SMPO. He has been organizing multiple conferences, educating young doctors coming in, and all the doctors with multiple levels of working and his own interest area development. He's been principal investigator more than 22 clinical trials, and then have successfully helped launch these products to India, and then helping patients to survive much better. He has been organizing wonderful congresses across India and geographies, and 16 international conferences to name him, which are on educational activities under his supervision being organized. He got more than 41 publications in various national and international repute of journal. So I welcome Dr. Shyam Agarwal as well. Sir, to you, good evening.
Thanks, Rajiv, for inviting and giving me this opportunity to chair this program. So I think we should not be standing between the speaker and the audience. So I think I'll request to sort of go ahead and initiate the proceedings of the program. Thank you very much, Rajiv, for the invite.
Thank you, sir. Thank you very much. It is indeed encouraging me to have you, see you, and hear you every time. It motivates all of us and helping me to do much better. Sir, now it's my privilege to introduce the program. Moderator for the evening is Dr. Kumar Prabhash. And trust me, Dr. Kumar Prabhash helped me conceptualizing this all, understanding this, how we can do about it. Dr. Kumar Prabhash is also a very eminent medical oncologist. We all know, does not require any kind of a introduction. However, he is with us, and I will be making his introduction when we are having his topic coming in. Before that, I would like to take you through introduction of our principal investigator of this subject today in Immunotherapeutic C today, Dr. Kamar with us. So happy to introduce you. Dr. Kamar is available with us, and Dr. Kamar has been working with Kerala for a long years, and then done a lot of clinical work, expertise, and then preclinical work, and he is the main person behind inventing this concept. So would request Dr. Kamar if he can take us through the journey of ICDEC C, and then we will go to Dr. Prabhash on the discussion of the different topics. To Dr. Kamar, please.
Good evening, everybody. I'm sharing the screen, or somebody will show the slides.
So you need to share the screen, please. We can see your
I have to
slide.
share the screen? Okay.
Yes, sir.
Is it visible now?
Yes, 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 yes.
Okay. So, respected Dr. Advani, Dr. Vait, Dr. Syam Agrawal, Dr. Kumar Pradwas, and distinguished oncologist. We have been working on this project for more than 15 years. And I'll just take you through the journey of what we have done as a basic science in the preclinical, in vitro, in ex vivo, and animal studies. And I'll also like to give you some brief outline of what can be done with this product. So I've divided my talk into some fundamentals of immune mechanism and cancer, mycelium as an active immunotherapy, and various aspects related to it. Desmocollin 3 in cancers, effect of chemotherapy and other therapies on desmocollin 3 expression, and small human clinical trials other than non-small cell lung cancer. All of you know that as tumor grows, the mutation burden grows and the outcome is poor. Now, mutations are eliminated by the immune system under ordinary circumstances. However, when they become large, multiple, they are associated with immune suppression. And when you have immune suppression, the tumor starts growing and tumor continues growing as shown in the right-hand side of the balance. And this is, standard, what is described in cancer immunology is elimination, equilibrium. Elimination is tumor is destroyed as soon as the cells start behaving abnormally. Equilibrium is, it is maintaining a small size, and escape is it starts growing. So how do immune system kills cancer? Or how do the tumor escapes from it? So if there is immune suppression or there's a lack of recognition of the tumor cells, then tumor cells escapes and they start growing. Immune suppression is induced by the tumors in form of various checkpoint inhibitors and other suppressive cells like myeloid-derived suppressor cells, Tregs, and lack of recognition is basically when the cell transforms to the cancer, various types of surface antigens are internalized or they disappear, and so body is not able to recognize them as a foreign cells. If you want to change it from escape to elimination, you have to provide either a positive signal or inhibit the negative signal. As Dr. Advani said, negative signal can be eliminated by using checkpoint inhibitor. But there's other side of the story that if you provide positive signal, then also you may be successful. So checkpoint inhibitors like Pembro, Nivo, Atelo, Durva, Avelumab, Sepilimab, they try to inhibit negative signal, while product like mycelium works on the other side by providing a positive signal. I'm just trying to get you through some fundamentals that if PD-1 is expressed on T cell or checkpoint is expressed on T cell but is not expressed on the tumor cells, the tumor will be killed as long as both the signals are activated, as shown in the arrow, green arrow on the left-hand side. However, when checkpoint inhibitors, receptor and ligand are expressed on both T cell and tumor cell, T cell get exhausted, it loses its function. And with the product like checkpoint inhibitors, you can neutralize it either at the T cell end using PD-1 antibodies or at the tumor end by using PD-L1 antibodies. And this will lead to neutralization of the checkpoint inhibitor and death of the cancer cell. If you look at who responds and who does not respond to checkpoint inhibitors, so responders are found to have high neoantigen load. That means body need to have pre-existing neoantigens or antigens which are for the same tumor expressed within the tumor. There has to be significant number of tumor infiltrating immune cells, which is also known as the inflamed type of the tumor. And then T effector and Treg ratio has to be high. So immune suppressive Treg has to be low, and myeloid derived suppressor cells need to be low. And then these cells need to have a capacity to secrete IFN gamma. And the person who don't respond, they have a high immune suppressive environment and very low level of NK cells or activated lymphocytes within the tumor stroma. And so these tumors, which are classically described as a desert type of tumors, they don't respond to the immune checkpoints. I'll just take you through the studies we have done. So we have done in various animal models, and they include melanoma, pancreatic cancer, myeloma, and tumor metastatic to the lung. And we have used various routes of administration, which includes intradermal, intralesional, intravenous, and we have used them as a monotherapy, as a mycelic alone, or along with chemotherapy and checkpoint modulators. So, and then this studies, animal studies has been done at 5 different institutes. One of that happens to be us, but then there were 4 independent institutes who verified it, did it on their own, and some of them is published. So 3 of them were in India, 1 was in US. So if you look at intradermal, in the melanoma model, given at the interval of 7 days, it delays the tumor progression. But when you give the same drug at a 10 times lower dose in the same frequency as intratumoral, the delay in progression is significantly better compared to the intradermal. And both are safe. And when you combine the two, there's a significant synergy. So intralesional plus intradermal, there's a significant synergy and there's a significant growth retardation, as seen on the slides on the left-hand side. Then we have also used this as an IV because there's a common misconception that any active immunotherapy given intravenously is not likely to work. But that's a misconception. So I would like to just show that when it is given IV, and this is a different kind of a mice, we have used different breeds of the mice, different routes of administration, different types of cancer. I'm just giving you a summary of what we have done over last 15 years. So then with intravenous also, there's a tumor regression, and this can be given multiple times. You can give it at the interval of one week or at the interval of every day or alternate day, and still you get the results. So it is safe and effective. But being an active immunotherapy, I mean, it is not possible to generate large number of effector cells which are required to kill a large size of mass tumor. And so it does not work in a large size of melanoma, as shown in this picture. And now I'm going to the pancreatic cancer, and same story. If you give weekly, there's a regression of pancreatic cancer. Intradermal, again, safe and effective. When you combine with gemcitabine, there's an improvement compared to gemcitabine alone or mycelic alone. Again, there's some synergy. And then when you give higher dose, multiple times or a one time. So in this, mycelic C was given 0.1 ml with gemcitabine. Mycelic C was given 0.5 ml plus gemcitabine, and mycelic C was given 0.1 ml for consecutive 3 days every week. And still, if you see, when given 0.5 ml or 0.1 ml for consecutive 3 days, the results are identical, but they are better than when it is given once a week. So it suggests that higher dose can provide better results and it is safe. This is the data with when we gave anti-PD-1 with mycelic C. And if you see the green line at the bottom, it suggests that both work as a synergy and the tumor growth is further retarded. On their own, both provide almost identical effect. And this is another checkpoint modulator, which is known as anti-GITR antibody. And this is a large size tumor. If you look at it when it was given at the, 700 millimeter cube, which is significantly large for the animal, which has a 40 to 50 gram of the weight. And then again, the tumor regressed completely. We have also evaluated the same in a myeloma animal model. And this is a interesting finding. So there is this model, which is considered to be very aggressive metastatic model for lung cancer, where the cancer cells are given in a very high amount in intravenous route. And then within 2 weeks, all animals die. They start showing metastasis to the lung on day 3 onwards. And there also, if you look at it on the same time frame, metastasis to the lung were delayed, and these animals survived 1 week longer. And according to the investigator who did the study, they have not seen any drug giving this effect in this particular model, which they are doing for now more than 20 years. They have not found a single product having this result. So it is possible to delay metastasis to the lung cancer in a tumor which is very aggressive. So what is Mycidex-C? Mycidex-C, the standard dose is 0.1 ml, which contains Mycobacterium W into 5 into power 10 to 8. This is essentially a non-pathogenic organism, which is of Indian origin, first identified in All India Institute of Medical Sciences. And in spite of being non-pathogenic, it is used after autoclaving. So the product which you get has undergone 2 autoclave cycles. And so we are 100% sure that it's not likely to cause any disease on its own. And the beauty of this particular organism is that in spite of getting killed, it retains its immunogenicity, which are unique in nature. And on the top of it, it is prepared in a sodium chloride. And we use thiomersal as a preservative so that you can use it same dose. If it has been opened, you can still use it subsequently. So what are the characteristics of this particular product? It is a very potent TLR2 agonist. And when we did this work in-house, we were not able to digest that work. So we went to InVivogen in USA, who is considered to be master in this activity. And they also came out and said that they have not seen any product which has such a potent TLR2 agonist activity. We did not stop there. We asked them what else it can do. And to our surprise, while it has no effect on other TLRs on its own, when they are overexpressed, as is seen in some cancers as an immune escape mechanism or immune evasion mechanism, particularly TLR4 and 9, it downregulates those TLRs. So if you look at the top chart, TLR9 is practically knocked out, and bottom chart, TLR4 is practically becomes half. So this works not only by providing immune stimulation, it also reduces immune evasion by working on toll-like receptors 4, 9, 3, 7, 8. I'm just showing you TLR9 and 4 data. Now, these cells are supposed to kill, and there is a test called effector function test. And we tried to optimize the dosage. So when you give a single dose, the effector function is this, 10. 2 doses, effector function increases, but the optimum effector function is when you give 2 doses at 2 weeks apart, as shown in this graph. So that tells you that if there are no other consideration, you should give this product at the interval of 2 weeks. I'm just showing effector function measured in a different way, just to show how it targets. So these are lung cancer cell lines. One is a desmocollin 3 positive, which represents squamous cell carcinoma. Another is a desmocollin 3 negative, which represents adenocarcinoma. Yellow one is a squamous, red one is adeno. And if you see that effector function, even at a smaller amount, I mean, typically when you do effector function, you have a dilution of 10 to 1 or 25 to 1. But even at 2.5 to 1, desmocollin 3 expressing yellow squamous cell carcinoma cell line gets killed. But there is no effect on adenocarcinoma cell line, which does not express desmocollin 3. We did not stop that. To make it sure, we neutralize with the antibodies either the effector cells or the tumor cells. And when you neutralize any one of them or both, effector function disappears. This tells us that the killing effect of the Mycidex-C is basically because of desmocollin 3 expression on tumor cells and immune cells. So when you give a single injections of Mycelium to the humans, it raises desmocollin 3 expressing immune cells in peripheral blood by around 40%. But when you give multiple injections, it goes to as high as 80% plus. And this happens is also supported by microarray data, where desmocollin 3 gene expression rises fourfold with a single injection intradermal of Mycelium, and it leads to protein expression, which are shown in the graph. And number of cells expressing desmocollin 3 are proportionate to the number of injections one receives. Desmocollin 3 is basically a cell adhesion molecule. It is a homophilic cell adhesion molecule. That means receptor and ligand are the same. So you need DSC3 on both the sides, unlike checkpoint inhibitors where you need PD1 on one side and PDL1 on the other side. Now I'll take you through whatever we have done, how Mycelium changes the human profile of the tumor bearing animals. So this was ex vivo data. Now you have a real in vivo data. So tumor infiltrating cells are increased following Mycelium. They are of various types. So you see on the right hand side, it is CD4, CD8, NK cell, NKT cells. And on the left hand side, and on the right hand side, you see dendritic cells and macrophages. So all types of cells get activated and they get increase in number inside the tumor. And this is important for killing of the tumor. And these cells are activated as represented by CD69 expression on them. And number of CD8 cells increases with injections, but more important, DSC3 expressing CD8 cells increases disproportionately, as you can see on this bar chart. So with a single injection of only Mycelium, DSC3 has increased, but DSC3 expressing CD8 cells within the tumor has significantly gone up. And there is a synergy when you give gemcitabine along with Mycelium, as shown in the extreme right bar. It not only increases desmocollin 3 expressing CD8 cells, it also has a decrease in FOXP3 cells, which are expressing CD4 type or CD8 types, and both are known as a Treg cells. They are responsible for immune suppression, and while CD4 and CD8 cells go up, which are immunostimulating in nature, immune suppressive cells within the tumor goes down. So it works on both the sides of the tumor microenvironment. It stimulates also, and it decreases suppression also. And further down the line, it also decreases PD1 expression on the tumor infiltrating immune cells. So essentially, it works on both the sides, as I mentioned before. It increases CD8 cytotoxic B cells expressing desmocollin 3 while decreasing Treg and PD1 expressing cells. And these cells, when unstimulated or stimulated, are capable of secreting IFN gamma, and these are IFN gamma secreting cell population measured by ELISpot within the tumor. And you see significant synergy when you have gemcitabine along with mycobacterium W. And its effect of tumor killing cells is dependent on cytotoxic T cells. As you see on this slide, when you deplete cytotoxic T cells, tumor killing effect disappears, as seen on the extreme right bar chart. It's practically not there. So to summarize, as we know, as we have seen, response is associated with increased number of TAI, tumor infiltrating cells. Mycelium is effective irrespective of route of administration, better effect with high dose, synergistic with other therapies, preferentially kills desmocollin 3 positive tumors, increases effector T cells which are activated, decreases immune suppression, and there's increasing tumor infiltrating IFN gamma secreting cells. So it meets the requirement of immunotherapy to be effective. Desmocollin 3, if you know, was originally invented because of the bevacizumab to differentiate between squamous cell carcinoma and adenocarcinoma. So it's a known biomarker for squamous cell lung cancer, and it is expressed in varieties of cancer. And what happens when you have DSC3 negative tumor? I will demonstrate that in next few slides. So desmocolin 3, as shown here on the right hand side of the panel, is expressed in the squamous cell lung cancer in the top right, in the basilar variant of large cell carcinoma, middle one, and clear cell variant of large cell carcinoma, bottom one. If you analyze all the published data of desmocolin 3 in lung cancer, it is found in around 80% of the squamous cell carcinoma, while it is found only in 2% in adenocarcinoma and around 11% of the large cell carcinoma. And this is all published by various authors while trying to study how to differentiate squamous from adeno. Now, when you give a chemotherapy and the tumor cells are desmocolin 3 negative, what happens? So before chemotherapy starts acting on it to kill them, desmocolin 3 comes on their surface and they become desmocolin 3 positive, as shown in the upper table. So all the tumor types which are desmocolin 3 negative, they become positive when you give cisplatin, paclitaxel, doxorubicin, and so many other drugs, including targeted therapies or TKIs. But this was reported. What we found was this happens even at a subtherapeutic dose. So you need not kill the tumor cells by therapeutic intervention in terms of chemotherapy or targeted therapy. Even when the tumors are not dying, they start expressing desmocolin 3, but this desmocolin 3 expression stays on the cell surface for a couple of hours, which is in the range of 24 hours. And if the cells are not going to die, they get back to the normal as desmocolin 3 negative tumors. And when they become desmocolin 3 positive, from negative to positive, the effector function goes high using immune cells immunized with mycelic C. So they become amenable to the therapy with mycelic C, as shown for various cells. So, I mean, blue is a no drug, pink is with cisplatin, and milder pink or lighter pink is with paclitaxel. And you see that there's a significant increase in effector function or cell killing when the tumor cells are exposed to subtherapeutic dose of chemotherapy, and then they're exposed to the immune cells activated by mycelic C. This is the same slide in a different way for a different types of tumor cells and different types of chemotherapy. Here it is gemcitabine and paclitaxel and different. So same story. So what it provides, if you have desmocolin 3 expressing immune cells and desmocolin 3 expressed on the tumor cells, it is possible to kill that cells following mycelic C administration, provided immunosuppression is not used, as I showed you in one of the slides where there was a significantly large tumor and there was no effect. So what are the mechanisms by which we can reduce the tumor-induced immune suppression? So any therapy which is effective will reduce immune suppression, and it includes surgery, chemotherapy, radiotherapy, checkpoint inhibitor, and when the tumor size is small, mycelic C alone. This is just to show you that ovarian cancer, which is difficult to treat, majority of the ovarian cancer has a desmocolin 3 positive, and the list of other cancers is melanoma. When they progress, they become negative, but up to a middle stage, they are positive. Colorectal cancer, 60% of the colon cancer are desmocolin 3 positive, 40% of metastatic liver metastases are desmocolin 3 positive. Bladder cancer is our own data, it was not known before. 60% are bladder cancer are desmocolin 3 positive. Meningioma is again 60% around positive. What we recently found is triple negative breast cancer, and this is based on the analysis of TCGA database. Triple negative breast cancer are more likely to be desmocolin 3 positive than negative, but other breast cancers are desmocolin 3 negative. Pancreatic cancer, significant number are desmocolin 3 positive. Chondrosarcoma, most likely desmocolin 3 positive. Oral squamous cell carcinoma of the mucous membrane likely to be positive at an early stage. At a later stage, there is a epigenetic silences and desmocollin 3 disappears. And people have described that a particular type of lymphoblastic leukemia, there is a gene expression, high level of gene expression of DSC3. Nobody has done immunohistochemistry to measure the protein's expression in this. I'll take you now to some of the small studies because my colleague will take you through the lung cancer data. So this has been used as a monotherapy as well as with chemotherapy, radiotherapy. And in monotherapy, it has been used with the bladder cancer, which is the obvious choice, and in advanced melanoma. And with chemotherapy, it has been used in ovarian and muscle invasive bladder cancer. So in this study, controlled clinical trial, which was IND was approved by US FDA, we had two arms. One arm received conventional BCG as a standard protocol. Other arm received intradermal, not intravesical, not into the bladder, intradermal over the arm, mycilexi every 15 days for 3 months, and then every month for 3 months, and then every 3 months, total 12 months duration. And if you follow the graph, both behave the same. Recurrence-free survival is identical, and it only tells you two things. One is, if you have a potent active immunotherapy, it is possible to treat bladder cancer by giving it remotely, which avoids all the challenges and problems associated with intravesical administration of BCG, which is again live and requires special precautions. While intradermal mycilexi can be outpatient procedure and does not require special procedure. But when we went to US FDA, they asked us to do a study that this is okay. We have a challenge in a recurrent unresponsive non-muscle invasive cancer. And this tells you that this type of tumor, which are non-responsive to the BCG, significant number has responded to the mycilexi, which was given again intradermally over the arms. And not only they had a response, they maintained the response for a longer time, which was designed by US FDA to be 15 months. But if you look at it, all the 7 has maintained recurrence-free survival for 30 months, durable response. And out of 7, only 1 was DSC3 negative because we have a small sample size, so that can be aberration, but all were DSC3 positive. So DSC3 positive, again, this gives us a confidence that this is the right biomarker for using with mycilexi. This study was done in advanced melanoma, and this was done again as a monotherapy. And they used it twice a weekly. Being aggressive tumor, they used it twice a weekly for 2 months, and they evaluated the response. And even in the human clinical study, they demonstrated that Tregs goes down, as shown in the middle picture. And then out of 12, which they recruited, 3 were alive at the end of study period, which was more than 15 months. 1 had a stable disease, and 2 had no evidence of disease. So this was significant, but since we don't have melanoma in this country, we could not pursue this. And this is a platinum refractory carcinoma ovary. They received etoposide orally for 6 cycles, and mycilexi initially was given twice a month between the cycle, and then subsequently every month as a maintenance cycle. Even there, those who completed the all 6 cycles, there was significant advantage in terms of overall survival. And this is a muscle invasive bladder cancer, which is advanced, came out of the bladder wall and lying on the abdominal wall. And they were treated with radiotherapy and mycilexi given every 15 days. And all of them had no evidence of tumor at the end of 3 months, and they remained recurrence-free for 2 years. So in summary, mycilexi is effective irrespective of route of administration. It can be given intradermal, intralesional, intravenous. It is safe at all dose levels that we have evaluated, and we have evaluated as high as 10 ml, which I am not showing here, 10 ml intravenous. It is a potent active immunotherapy in form of TLR2 agonist, but at the same time down-regulating TLR9 and 4, and it is associated with increased activated tumor-infiltrating immune cells, which are of a effector function. It preferentially kills plasmacolin 3 expressing cancer cells and is effective as a monotherapy in relatively small tumors like melanomas, bladder cancers, but it requires co-therapies and is synergy with effective co-therapies in advanced tumors. Thank you. Thank you very much.
Thank you, Dr. Kamar. Thank you very much for your deliberation on this. This takes me to immediately go to Dr. Amit Kumar Verma, the medical advisor from Kedla Pharmaceuticals Oncocare business, to take us through quickly on the clinical part of the program, what we have done with the MyCDC in India. With this, while he sets up the presentation, I also formally welcome Dr. Surendra Beniwal also joined us, and he is put through a chat box question also data on ovarian cancer. And I'm sure Dr. Kamar have shown one slide and we'll give another slides and insights after maybe discussion. We'll do that. And then we have Dr. Krishna Prasad also joining in from Bangalore on the program. Dr. Bharat Patodia joining in for the program. Dr. Ghanshyam Biswas all the way from the Katak joining in for the program. Dr. Amit, please continue so that we don't surpass time. And we have to have listened Dr. Kumar Prabhash and then other eminent doctors who have up till now used MyCDC and their experiences. Yes, Dr. Amit.
Yeah, respected sirs and dear colleagues, good evening to all of you. And thanks, Rajiv, for giving me this opportunity to speak about the MyCDC here. So my talk is going to be focused upon the clinical studies which have been done upon the MyCDC. So I'm going to be starting with the one pilot study that was initiated. So upon the MyCDC, it was open label, randomized control clinical study of desmogonity targeted toll-like receptor agonist MyCDC, microW in the advanced non-small cell carcinoma cases. So this was the 48 patient clinical study. And in the study arm, there were 26 number of patients were there. And in the control arm, there were 22 number of the patients were there. And in this arm, like chemotherapy was given in the terms of cisplatin plus etoposide as a platin. And in the study arm, along with the chemotherapy, the MyCDC intradermally was added 0.1 ml fortnightly for the period of 6 months. So it was given. And when I talk about the patient characteristics in these, both of the two arms, they were similar in nature in respect to age, gender, performance status, and the stage of the disorder. So all these patients were actually being suffering from the advanced disease, NSCLC. So this was the output which I would like to elaborate here to, which was found after the conduct of this pilot study. So in the terms of the response, it was found to be 11% better versus the chemotherapeutic arm. So it was 11% better with the MyCDC arm. And when I talk about the progression of disorder, progressive disease was found to be 19%, which was pretty lesser in comparison to the chemotherapeutic arm. And one more good output was seen after the conduct of this study was one patient was seen with the complete response in the treatment group, but none in the case of control arm. And when I talk about the adverse drug reactions, so when the data was compared in between the study versus the control arm, the side effects were actually found to be lesser with the study arm, which was containing where the MyCDC was given versus the control arm here. So pneumonia, or you talk about chest pain, asthenia, vomiting, or hematological side effects, they were found to be pretty lesser in the MyCDC arm. And when I talk about the larger clinical study, which was open label, randomized controlled clinical trial of desmogonity targeted toll-like receptor agonist MyCDC in the combination with the platinum containing doublet versus chemotherapy platinum containing doublet in the advanced non-small cell lung cancer cases. So here the patient number was 221, and in the MyCDC arm, 109 number of patients they were recruited for the study. And for the control arm, only chemotherapy was given, where the number was patient number was 112. So again, all these patients were suffering from the advanced disease. And for chemotherapy, the paclitaxel with the dose 175 milligram per square meter of body surface area plus cisplatin was used for the therapy as a standard 21-day cycle. And talking about the immunotherapy, MyCDC 0.2 ml was given 7 days prior to the first day of chemotherapy, followed by the 18th and 15th day. And these patients were continued for the 4 chemotherapeutic cycles, and post completion they were being given with a one injections monthly. And this study was being conducted to compare the overall survival in the mycedexy arm versus the control arm. And talking about the secondary objectives, they were including the progression-free survival, response rate as per the RECIST 1.1, and the toxicity profile was being noted. And patient profile, as I said, all these patients were suffering from the advanced non-small cell lung carcinoma, and they were being treated with the platinum-containing doublet. So to elaborate upon the efficacy here, this was found after the conduct of this study. When I talk about the overall survival, it was found to be 10% better versus the study arm versus the control arm. And talking about the progression of disease, like there were pretty lesser number of cases with the mycedexy arm and found to be 5% better versus the control arm here. So 11% cases were seen with the progression of disease versus the 16% in the platinum-containing doublet arm. And 3 cases of the complete response was seen with the mycedexy arm, but none in the case of chemotherapeutic arm. And so it was concluded that mycedexy is improving the response rate in such kind of the patients. And talking about the overall survival in the case of squamous variety cells, like mean survival time was found to be 100 days better versus the chemotherapeutic arm here. And talking about the overall survival of all these patients, like it was found to be 66 days better versus the chemotherapeutic arm, and the hazard ratio was pretty beautiful. It was 0.64 here. So talking about the adenocarcinoma, here it was 280 days versus the 227 days in the platinum containing arm, and the HR was 0.68 here. And to elaborate further here, like it was found to be increase in the overall survival in the mycedexy arm in the patients who were actually being suffering from the squamous variety of the NSCLC. So hazard ratio was found to be 0.55 here, and improved overall survival was seen with the 127 days in the ITT population, 299 versus 172 days here. Talking about this further here, mycedexy was found to be synergistic to the platinum-containing doublet. It improves the progression-free survival with the hazard ratio of 0.43, and also improves the overall survival with the hazard ratio of 0.64. And squamous variety was found to be best here, with the HR of 0.4 here. And talking about the adverse event, it was not found to be associated with any kind of the raised systemic side effects. But some cases of the injection site reactions were found with the clinical study. Now, talking upon the toxicity here, as I said, like hematological side effects as well as the non-hematological side effects, they were not raised after the administration of the immunomodulator mycedexy here. So it was not being found here, same has been elaborated here. To talk upon this further, it is non-hematological side effects. Again, they were not raised with the study arm here. And this data was actually being published in the Annals of Oncology by Dr. C.V. Bilani as well as our R&D director, Dr. Kamar here. And it was stated that benefit of addition of KD05 in the platinum-containing doublet has improved overall response rate, progression-free survival, overall survival was seen with the patient who actually completed the 4 cycles of the chemotherapy in the newly diagnosed chemotherapy-naive advanced NSCLC patients. And benefit was found to be maximum with the squamous NSCLC known to express the desmokalin-3 in the ITT analysis as well as those in the patients who completed the 4 cycles of the chemotherapy. So the key highlights of the study, they included addition of the KD05 to the platinum-containing doublet has the trend towards the improvement in the progression-free survival with the HR of 0.69, and addition of the KD05 to the platinum-containing doublet improves the overall survival with the HR of 0.64, and progression-free survival with the HR of 0.43 here in the pre-specified subset who completed the 4 cycles of chemotherapy. And efficacy of KD05 was better in the patient with a squamous variety of the carcinoma. So addition of KD05 was not found to be associated with increased systemic side effects. And here I would like to elaborate the data upon the another pilot study which is conducted at PGI Chandigarh. So it was intravenous mycedexy as a radiosensitizer to the radiotherapy in the locally advanced stage 3A, B cases. So Post-randomization, patients with a locally advanced chemotherapy, naive patients, stage 3, they were recruited for the study with the ECOG performance status of 2 or less than that. So 0.1 ml of mycidex was given, twice monthly plus pre-medication of the dexamethasone, and along with the radiation therapy every month, 0.1 ml was given. And they were treated, up to 12 months until CR or position of disease or unsusceptible toxicity. And talking about the other control arm, here the chemotherapy or the radiation therapy was given as per the investigator choice. Again, they were treated until the position of disease or unacceptable toxicity, or the person who has taken the consent back. So the primary endpoints of the study, they were overall survival, objective response rate, as well as the safety, progression-free survival, EOCT, quality of life, as well as the treatment to failure. So the key outcomes of the study were like this. So in total, 10 patients were recruited for the study, and out of which 8 have started with the treatment as per the protocol. And the results had the noticeable improvement in the ECOG status, overall quality of the life, as well as the objective response rate. In the patients recruitment in the test arm receiving the mycidex along with the standard radiation therapy, compared to the subjects recruited in the control arm receiving the standard of care, that is radiotherapy only, and one patient experienced the serious side effect with the anaphylactic reaction, and one patient actually died in the control arm. So to conclude the talk here, platinum-based chemotherapy has been the first-line therapy for most of the patients with the squamous non-small cell lung carcinoma since last 2 decades, reflecting a significant unmet need for treatment advances in this patient population. A study showed that the addition of the Mycobacterium W to the platinum content doublet in the patients with the advanced non-small cell lung carcinoma seems to be safer and safe and almost free of systemic side effects. And this study also showed some improvement in the positions of survival and the overall survival. So with this, I would like to say thank you very much for a patient listening. You can proceed further.
Thank you very much, Dr. Amit. Thank you very much. You took us through, other than lung cancer, multiple lung areas. So Dr. Kumar Prabhash must be wondering on this. This takes me to him, Dr. Kumar Prabhash. Happy to introduce him, though he does not require any kind of introduction to any forum in the oncology or medical fraternity in India, for say. However, let me do my duties, otherwise I'm failing on my company duties. Sir, he's done his MBBS MD from the Maulana Azad Medical College, New Delhi, DM from Kidway Memorial Institute Oncology, Bangalore, professor and head for HOD Department Medical Oncology, TMH. To his name, many initiatives and many activities includes organizing various different types of meetings for the TMH and then international faculty invited. He started a preceptorship program, which is one of its kind program he started in the hands of training molecular methods of medical oncology in molecular laboratories. Developed teaching videos for the molecular methods comprising these methods. He started 1-year training program in the medical oncology molecular laboratories. Is a guide to all DM resident students for the last 8 years, PhD guide for health sciences activity. PhD students receive a Prime Minister Fellowship Award. Published guidelines include skin toxicity management of EGFR TKIs, recurrent and metastatic head and neck cancers, management published advanced renal cell cancer management, advanced lung cancer management, esophageal cancer management by ICMR submitted. To name his publication, PubMed, Index Journal, approx 300 publication, so on and so forth. If I keep on reading about him, is such an academic recognition amongst us available who can take us through to the different level of medical science in oncology today. So I really heartily welcome Dr. Kumar Prabhash for this. Over to you, sir.
Hi, good evening, everyone. At the outset, thank you for organizing this. And what we'll do is primarily, this is less of a panel discussion, more of it is experience sharing and also having some guidance for Cadila that where we look for this drug in future. So what I'll request all the participants to maybe if they can put their view in 3 aspects. One is we have seen the data. two wonderful presentations. I have heard this earlier also, and if you heard first time, sure, it looks exciting. How good is the data? How convincing is the data when you look for it for your clinic? Second part, what I will request everyone to share their experience when they have used it, how good they felt, and what were some problems. I saw some of the problems shared by someone on the chat, and those are important ones. And we do have a key people here who can give you some solutions. And third, what do we think we need to be done with this molecule so that it can develop in future in many more settings and many more situations? We can start with Dr. Dattatray. Dr. Dattatray, these three situations, those three issues which I put, your view on that. Dr. Dattatray had joined. I saw him there.
Yes, sir. He is here. I also saw him.
In case if you are trying to.
Yeah, he's here, sir.
He's there.
Yeah, he's there. I can see him. He's there very much.
He's able to unmute, or if he's not, then in the meantime we can have other opinion and we'll come back to him. Dr. Vamshi is there. Vamshi.
Sir, I'm there, sir.
Hi, your view on these three issues for this drug.
Sir, to be honest, I have prepared this. I have not used the drug personally, but going by the data, it seems like the biologically it seems to be a plausible drug. It is working on a TLR2. It seems to be working on immunotherapy, so it seems to be a drug which should be effective. I was going through the data when it was being presented, an increase around 10% of the PR, stable disease slightly the same, and reduction in the progression. And these were three things which really stuck out at me. So I think it's a good drug, and we have to really use more of it to get used
to. Thank you, Vamshi. Dr. C.T. Satish, your view on.
Sir, we also have joining in Dr. Bowman Dabar have joined us. Dr. Piyush Bajpayee from Delhi joined us. Dr. Tushar Patil also joined us.
Okay, I will be requesting all of them.
And yes, this is Dr. Satish speaking, sir. Yeah, I think it is a very we know that we are having a limitation about cost issue in our India. The data is very impressive, but practically I have not used actually this drug. I know that we have conducted TMH also done Jeftinib and Femdex combination, how we have done. At least we should have some big number. We have some at least we have some multi institutions, some small number. If we do that one, you can see that one. But I think we may not able to offer immunotherapy expensive drug for many patients. At least this can be used in few cases. We should see that one. I think it's not like by using this drug is going to cause any toxicity more or anything. At least it is more economicalized. It is very impressive. I think some of few cases I'll consider, especially small squamous cell carcinoma. Those are not having any no driver mutation or those. I'll try to change my practice. Some of the patients.
And your comment on the safety aspect, injectable site reactions.
Sir, see, this I have not used actually. That we have to see that that's what. So yes, for the data, it is not that much very. I think we have seen that so many we medical oncologists we have tried to be very expensive with even managing a extravasation, all those things. I don't think you should. But only thing is if these kind of things develops during the course of treatment, should be very careful. Is there any reactivation of anything? The best all those things should be very careful and should monitor them. That's what. I don't think it's very grave or anything should be scared to use this drug. That's what I want to say.
Thank you, Dr. Satish. Dr. Surendra Beniwal, he wanted to make a comment. Sir, please go ahead, sir.
Sir. I have used this drug in lot of patients, and the main side effect is that the local side effect. And what is my experience is that in most of patients, when we use either we can wrongly give subcutaneously or sometimes intradermally, then these side effects are more common. Otherwise, except local side effects, this drug is very safe. And recently, with the help of Cadila, we have started one trial in IV, and we have taken approximately 10 patients. and no one has any drug reaction. We cannot comment on the effect, but the on the side effect perspective view, intravenous drug is very safe, and none of the patient has any side effect when we use intravenous.
Very important comment, Dr. Beniwal. Maybe we'll come to Dr. Kamar. Dr. Kamar, do you want to comment regarding IV route versus intradermal? Because this issue comes with this drug multiple times, and good to hear that Dr. Beniwal has used IV and he is fairly comfortable with it. Yes, sir. Go ahead, sir.
So we are aware that intradermal injection is tricky, and side effect comes from two reasons. One is a faulty site or faulty administration. The other part is essentially increased immune reaction at the injection site. So even when I give it appropriately, some of them will have it at the local site. And this is an indication that immune reaction has reached to its maximum and you should discontinue giving more. Because more you give after that, more local side effect will worsen. And this is essentially because when you give this drug at the local site, it behaves like a depot and immune reaction gets maximally concentrated at the local site, wherever you give it. And sometimes it is seen that when you have given one injection, there is no local site reaction, second injection, no local site reaction, third injection, no local site reaction, and fourth and fifth will have it. The other part of the story is to avoid that, you should give 2 injections as much apart as possible because immune reaction is site dependent. So we recommend that keep minimum 1 inches distance between the subsequent injections, preferably rotate the site, and there are 3 major sites where you can give this intradermally. One is upper arms, second is around the umbilicus, and third is around inner side of the thigh. These are preferred methods of giving intradermal immune activators, and they are worldwide recognized. This is not something which we have invented. The second part of the story is, it is difficult and tricky to give intradermal. So what you can do is, as Dr. Beniwal said, you can give intravenous. And as I mentioned before, we have given intravenous as high as 10 ml. The only precaution is that this is a biological material which gets into the system so fast in such a high amount. So to prevent adverse events, which are typically like infusion reactions, you must give, and I will repeat, you must give steroid 2 ml dexamethasone or equivalent 1 hour before giving intravenous Mycidex C. There is no limit how much amount of Mycidex C you can give, but must give, I'll repeat one more time, must give 2 cc of dexamethasone or equivalent injectable steroids intravenously. Once you do this, you are safe. And there will not be any side effect, as Dr. Beniwal said, because this drug does not have any systemic side effects on any organ. It is only that local site injection when you give intradermal, and when you give IV, if you have not preloaded or preempted with corticosteroids, you are likely to have once in a while severe infusion reaction, which may lead to hypotension, and it might be worrisome. So whenever you try to give intravenous, please give 2 cc dexamethasone 1 hour before intravenous. And that's easy for oncologists to give because you always give chemotherapy to the same route. So you don't have to change the site and you can continue doing the same. Thank you. Is there any more, Kumar Prabhas, that I need to answer?
Yes. No. So this was very useful because that is one of those aspects which comes out from many people. One more. So you made a statement that you're very certain about the side effects. These trials were small. Where you are so confident about side effects, because I'm aware of data, so I want that this to need to come out. You're so certain about side effects. So it means that you have used this drug in multiple places, multiple settings. Do you want to say that? You want to put those numbers so that people get to know how many places, what number of patients has been used? So when you say that you are very certain about side effects, why do you say so? Go ahead, sir.
Okay, so let me go one by one. So as a ophthalmologist, we have used this as a 5 ml intravenous in more than 200 patients following dexamethasone for refractory optic neuritis. Optic neuritis is like a multiple sclerosis, and you give high dose methylprednisolone 1 gram daily for 3 to 5 days. And those people who had a suboptimal or no response to methylprednisolone 1 gram given for 3 to 5 days, they were subjected to this drug and none of had side effect. Intradermal, large cohort in India has investigated this drug for various indications. And if I take you through, so the first cohort was 22,000 patients. The next cohort was 10,000 patients or subjects. And so various clinical studies has been done, but none of them have showed side effect. So before we entered into this cancer area, we had a data of around 100,000 subjects, patients or healthy individuals given this drug intradermally. And none of them had reported, and 50,000 has been on the control clinical studies. So none of them have reported any side effects, and local side effects were minimal because they were given very apart. Unlike cancer and other diseases where you have to give it every 15 days, these were given 3 months apart, 1 month apart, 15 days apart. So that's the huge safety data which is available on this product.
I agree, and that's the reason I thought it may come out when we talk about safety. So that reassures people when they want to use it. Maybe we can go ahead with the comments from other participants. Dr. Prem Kumar.
Dr. Dattatreya also is there.
Kumar, this is Dattatreya. Sorry, I could not respond at that time.
Hi, Satya. Please go ahead, sir.
Hi, Kumar. So I have used this drug quite some time back, and it was in the intravenous form, and as was previously mentioned by one of my colleagues as well, that the adverse event profile seems much less in the IV format. Number two, we are not really sure whether internal injection really happens or not. So for that reason, I think the input in the form with our learned speakers today, that IV is one thing which can be done without the efficacy getting compromised, is a very important take-home message.
Okay.
Again, I have not used in many patients, but then the data looks quite compelling because we are now in the era of immunotherapy and immuno-oncology. And when patients can't afford costly drugs like nivolumab or pembrolizumab, this drug can come handy to us in the treatment of non-small cell lung cancer. So I think all of us should collaborate to make sure that we have our own data, and then if we can look forward to an interact among ourselves, it might be a promising drug to use, a very good adjunct drug to use in non-small cell lung cancer.
Thank you, Satya, for your comment. Dr. Prem Kumar. Dr. Prem Kumar is there. Not, we can go to Dr. Suman Kalyan.
Yes, I'm here.
Yes, sir. Please go ahead, sir.
Yeah. So, sir, my experience with the drug, I have used it in about 4 patients till now. So one thing that is bothering, as someone already pointed out, is the local reaction. It looks like a vaccine mark, obviously. So this happened in almost all the patients. And that efficacy, in my personal experience, I'm at a stage to comment. So I used in lung cancer patient along with paclitaxel.
Okay. Thank you, Dr. Kalyan. Dr. Sachin Almel. Dr. Bowman.
Dr. Sachin was going somewhere, so I think he's
if he joins, we'll come back to him.
Yes, sir. Yes, sir.
Dr. Bowman Dabar, sir.
Sir, you're
yeah. I heard everything, and it was really very interesting. And experimental data also looks very encouraging. Although I must tell you, in this age, number of patients more would have been always welcome, especially when you are treating patients in those. But of course, it is very interesting, and squamous cell carcinoma is usually a disease of the third world. So it is we only who have to take this ahead. So in squamous cell carcinoma, of course, now we have immunotherapy. We have got so many things again coming up. So in this context, but of course, we know hardly 5 or 10% of our patients would afford this type of treatment, immunotherapy. So in such a group of patients, but one question I wanted to ask, we are so much concentrating on intradermal on this. Is it possible to give this drug subcutaneous, or there is no? Then it becomes very simple. No?
Sir, I agree with you. That is far easier. Yeah, I agree. No, why
Intradermal
to IV? Why to go in the daycare? Come on.
Any?
Can I respond?
Yes,
yeah. We want to hear from you.
Yeah. So, okay, I'll tell you background why it was developed as intradermal. Intradermal site has maximum Langerhans cells. So the immune responses are better. Even when you look at the vaccines, say for example, rabies vaccine, when you give intradermal instead of intramuscular, the dose gets reduced by almost 30%. I mean, it becomes 1/3. So intradermal is the best place for immune therapy because small dose, you can do wonders. It manifests very quickly when you give intradermal, though people may not agree, but it manifests also very quickly. Now, when you change from intradermal to subcutaneous, that privilege is gone because there are no Langerhans cells. So it becomes as good as intramuscular. And since it becomes as good as intramuscular, you are more likely to have inflammatory response and less likely to have benefit. So it will hit you on both the sides. Patient will have, and I have seen them, patient will have a huge abscesses on the arm if it is given subcutaneously. Not everybody develops it, but it may happen, and I've seen them. And they are not likely to develop any benefit out of it or a minimal benefit. So if you are not confident, if you are not comfortable with intradermal, please give intravenous, but please don't attempt intramuscular or subcutaneous.
Thank you, Dr. Kamal. That was very informative. To comment ourselves, sir.
Yeah.
Your comments, sir.
Yeah. So it looks very promising theoretically, and what data we saw, of course, a small number of patients, but look very promising. And in squamous cell carcinoma, when we don't have really major treatment options, when we are not going to use immunotherapeutic agents, which as all of us know, maybe possible in 5% of our population or 10% of our population of patients whom we see. We don't have any great drugs here. We do not have TKIs. We do not have much to use. So in this, and especially in squamous cell carcinoma, where it has shown a response, means I would be more than interested to try at least in some of our patients just to get the first-hand experience how it will do in our patients. And when we are used, and any data with gemcitabine is there, or most it's Paclitaxel and carbo only?
I can remember there is. Dr. Kamal, do you want to share? There was some data for you with combining with gemcitabine. Am I right?
Yeah. So okay. So I mean, if you combine with gemcitabine has a significant advantage over paclitaxel in certain terms from an immune profile perspective. So from an immune profile perspective, gemcitabine is known to reduce significantly immunosuppressive cells compared to paclitaxel. So there is no contraindication to combining gemcitabine with mycid-XC. On the contrary, it will, in my view, it will be better compared to cisplatin paclitaxel versus cisplatin or carboplatin versus gemcitabine.
Does the schedule change for gemcitabine versus paclitaxel?
Yeah, okay. So, I mean, essentially, what you have to do is, as far as possible, you don't give a drug at the time of chemotherapy, because at that point in time, immune cells are getting destroyed. So you position in such a way that it comes between the 2 cycles of chemotherapy. So you give 1 week in advance of chemotherapy or 1 week after chemotherapy. that's the best time to give active immunotherapy. So you can plan whichever drug you want to use in whichever sequence you want to use it. Try to give it 1 week before or 1 week after chemotherapy.
So idea that gemcitabine date becomes a challenge, and that time one needs to be a bit careful. So again, a very important insight and a very important question by Dr. Bomandaba, sir. As usual, sir, please continue with your comments, sir. These are very informative, sir.
Thank you. Thank you, Kumar. So I think so we'll be more than happy to use this drug and try out in few of our patients, especially when the toxicity is not there. Only a little bit hitch again is 7 days before we have to use. All our patients are usually in a hurry to start the treatment. Once they know it's a malignancy, we tell them we are doing biomarker studies. They say, oh, you are wasting time. So this is a small hitch, 7 days earlier giving it. But of course, that is our duty to convince our patients. And I think so. I would be more than happy to try it at least in few patients. What about you, Kumar? You have tried?
Sorry, sir, I missed your last.
Have you tried, Kumar?
Sir, I have tried, sir. I have tried, intradermal. I have tried some IV. Intradermal is a challenge, sir. I know that was the right comment many people have made, and absolutely right. It tests after 2-3 doses. Patients starts, they become a bit wary. IV is safer. So safety-wise, I also agree with the comments by all the people who made. IV-wise, it is safer. Haven't come across trouble. Efficacy-wise, your comment was absolutely right, sir. Data is promising. We are very keen. We all need to come together to give a better answer to them. So that we are more confident in our practice. But yes, safety-wise, it is good, sir.
One more advantage of IV is that dexamethasone by default does go as an antiemetic. So we are not likely to end up in any complications with this injection and give it IV. But just make sure it goes after the antiemetic protocol. And that should definitely include dexamethasone.
But we are not going to give it along with chemo, no?
Along with chemotherapy. So
it is separate quick.
So does I. Separate quick. Dr. Shailesh, your comment? Dr. Shailesh?
Yes, I am there. First thing, I think Rajiv has picked up many people who actually wanted to use it but has not used it, and I am one of them. So data looks really promising. I think something like Kumar said, we need to look into and we need to collaborate to use it because most of our patients where immunotherapy is an indication cannot really go for immunotherapy. So we should look out for an alternative where we can use it in most of the patients. Another challenge which I was thinking of is giving it the IV drug with steroids. I mean, there is a lot of talk about steroids and immunotherapy. As this is having an immune part of it, whether steroid will hamper the activity of the drug is something I think we can take that as a
good
small
question,
comment.
Shailesh. Dr. Kamar, steroid one day does have any impact like in other immunotherapy drug when we use prolonged steroid? It has some bearing.
So okay, so let me take. So steroid works in a different way, and steroids. Hello, can you hear me?
Yes, we can. Dr. Shailesh, I'll come back to you again.
So steroids work in a different way, and whatever experiments or clinical studies we have done, immune stimulatory effect of mycelium is not hampered by concurrent steroid use.
Okay.
And on the other side, its anti-inflammatory effect, which is TLR4 and 9 dysregulation, P38 down regulation. I mean, I'm not going into all those technical aspects which will happen at a molecular level. All those effects are significantly more powerful than steroids. So I will not hesitate in using steroids.
So say one day steroid is okay.
Yeah, it's not going to do anything. It's not going to do anything.
Thank you, Dr. Kamar. Coming back to Dr. Shailesh, any comments? Any further comments?
Yes, I think this we should use it. We use this molecule looking at the data because I don't know whether we can have a small study of immunotherapy versus plus chemotherapy versus this molecule plus chemotherapy and see is there something in that.
I think so. We should, knowing Shailesh, a very avid researcher, we should have some protocol together. We should 10, 12 people in the team. We should come together and do it. We moved on to Dr. Ghanshyam. Dr. Ghanshyam, any comment from your side?
Hi, Kumar. So first of all, so I've used in 2013-14. So we tried to take this molecule many a times. And so Dr. Khamar is there and Dr. Kumar. So both of you know. So, and so there have been so many hierarchical changes in the Cadila, and now Raji wants to take off. I don't know so how long he continues. So it is not with the products, but it has been with the system. So probably among the group today, so probably I have the highest users of MySeedXC. So yeah, so we had Kumar, we had a meeting in Kolkata also. So Cadila wanted to tie up with Abbott also. So we had another meeting also. So I did another presentation in one of the icons at Patna also. So we do agree that intradermal was a problem, and we have many times I have reached to Dr. Khamar also. He said, so maybe this is a mistake by maybe it was a subcutaneous. So that's why we land up with so much a bad and horrible experience from the patients of the drug when they're using intradermal. So two settings, so squamous cell carcinoma, and today in 2021 we are talking about non-druggable mutations in the adenocarcinoma group. So where we definitely understand that we need some drugs. So Cadila from here onwards, so maybe as we're discussing about paclitaxel in the squamous group and in the non-squamous group, maybe because the pemetrexed and platinum is the forerunner. So we can have a protocol, and those who are in the meeting today, at least, so they should combine, and we can, so in 6 months, 1 year time, so we can have a good amount of, and we can stop discussing about that 48 patient, 58 patient data, and we can have at least 200 patient data, because we are talking about a squamous cell, which itself is a 30% population. We are talking about adenocarcinoma, non-druggable mutations, and another 30% of the patient population. Even there are patients who will have a PDL1, high PDL1, but they cannot afford immunotherapy. So that can be another group. So where we can see this drug, and we can have a beautiful patient. So three types of disease in the same cancer, lung cancer group, and we have all set to go.
Thank you. Thank you, Dr. Ghanshyam.
Thank you, Dr. Ghanshyam. Remembering my name. Thanks a lot. I'll do my bit.
Go to Dr. Chari. Dr. Chari is there. Dr. Manohar Chari.
Yes, sir. He is there. I just saw him. He's there.
So if he's not able to, then we'll come back to him. Dr. Deepak Dabkara.
Yes, sir. He's there.
Deepak, I saw. Dr. Deepak.
Hello.
Hi, Deepak.
Yes, sir. Hi, sir. I have not used this drug, but the study is very promising. It looks very promising. And as others have pointed out, that in squamous cell carcinoma, we don't have much drugs. Suppose we have used paclitaxel in first line, then there is nothing in second line. And nivolumab is the only drug most of the patients cannot afford. And so I will like to use this drug. Till now, I have not used.
Sir, we have Dr. Ayan Bhattacharya.
Deepak, you wanted to complete? Let me, we lost you.
No, sir, I have completed.
Oh, okay. Thank you, Dr. Deepak. Dr. Naresh Somani?
Sir, he's not around. He's not around.
He's not around? No. Dr. Piyush Bajpayee?
Yes, sir. Good evening. So I have not used this drug, but of course the data is looking good, and only that my concern was, of course, about the intradermal use. When I saw the blister question also and read the monograph, product monograph, so that was a bit concerning. My question is that there would be several patients who would have tuberculosis earlier. Would this drug be still useful in these patients?
Dr.
the previous
Dr.
history of
Kamar,
tuberculosis.
Yeah, I agree. This was initially being developed for similar kind of use. Dr. Kamar, any comment?
So short answer is yes. Even if they have active tuberculosis, this drug will help them in faster sputum conversion. Okay. So we have a tuberculosis studies where this drug has improved sputum conversion rate preponement by 4 weeks out of 8 weeks. And it has also been used in small numbers for multi-drug resistant tuberculosis where there was no response to conventional therapy. And when this was added, they started responding. There was a sputum conversion. So by all means, you can use in presence of active or healed tuberculosis. No contraindication.
I was trying to ask another perspective, sir. Would it still be useful if there would be a lot of previous history of tuberculosis in patients, healed tuberculosis, treated tuberculosis? When we are talking about the antigen presentation, so would it still be useful? I'm just asking. So
yeah, yes. So I mean, when you have a healed tuberculosis, your immune profile is different, and then you give this drug, immune profile will change as if you were normal, healthy individual. So there will not be any difference in immune profile when you have a healed tuberculosis versus you have no tuberculosis.
Okay, so Piyush, any other comment?
no, sir. So data looks exciting, and definitely, as other panelists mentioned, that those where the economics are a challenge for using immunotherapy, this drug is looking something promising, especially in the squamous cell carcinoma. Yes.
So, Dr. Saptarishi, any other comment from your side? Dr. Saptarishi Ghosh? Dr. Beniva, I'll come to you. Okay. Dr. Mahapatra?
So Dr. Mahapatra's mother is not well, so he just...
No issue. Dr. Benival, please comment, sir.
Sir, I want to ask you 2 questions. My first question to Kumar Pravasar, Dr. Ghanshyam and Dr. Kamar. If a patient develop side effect, local side effect, then there is trouble. 1 or 2 of my patients has local ulcer waxing and waning from last 1 year. So how we can tackle if patient develop local side effects, and how we can tackle them? Is there any different treatment, or we can treat like a simple local ulcer?
I missed your last comment. Please, can you repeat again?
If patient develops local side effect, especially ulcer, then how we can tackle them? Because 1 or 2 of my patients has local ulcer waxing and waning from last 1 year. So we have to treat them differently, or we have to treat simple, we give antibiotics and some other things? Or is there any local anti-tubercular drugs?
I got your point. I got your point. Yeah, I understood. I didn't have any patient with event ulcer was there for years, but I agree it is possible. Dr. Kamar, any AKT or something?
No. Okay. So since this is a killed organism, whatever you are seeing as a local side effect is exaggerated immune response.
Okay.
So
it is not the
essentially, they don't need any local treatment. They will keep coming up and down. But if it becomes bothersome, what you can do is you can ask them to apply tacrolimus skin ointment. Okay. That will reduce the local immune response at the site of injection, and that might be of help. But other than that, they don't need any treatment. It's really bothersome for the patient, because once in a while it comes back and then it disappears and comes back and disappears. It happens in small number of people. It does happen.
Okay. And my second question to Dr. Kumar is that as we all know that immunotherapy is less effective in non-driver mutation positive non-small lung cancers. Have you got my point? As we all know that the immunotherapy is less effective in driver mutation positive lung cancers.
So driver mutation positive lung cancer, is it as good or is it less effective?
Are you having any data?
I'm not aware. Dr. Kamar, any data on driver mutation positive versus driver mutation negative patients?
driver mutation negative were all part of the study, so we have that data. But driver mutation positive, first I will go through the science. Why immunotherapy does not work in driver mutation positive? Because they don't have exhausted T cells. They actually, all TKIs activate T cells. So when there are activation of immune system, and that's the reason lot of skin related side effects are essentially activated T cells. And there is no significant inflammation within the tumor. So these are two major reasons why checkpoint inhibitors don't work there. Because checkpoint inhibitors requires inflammation within the tumor and minimal activation of T cells so that they can boost it. But mycelic works in a different way. As a matter of fact, we hypothesized long back, we have not put into the practice. We have a small number where we have used. But actually, if you combine the two, the duration of response is likely to go high and depth of the response is also likely to increase because both are working through the same mechanisms. Both are increasing your immune response. And typically, all driver mutations are desmocollin 3 negative. But when you give TKIs, they became desmocollin 3 positive. And this is a work not done by us only, but this is a work published by German group, those who were pioneering desmocollin 3. So they have beautifully shown that gefitinib brings desmocollin 3 back on the surface. And once the desmocollin 3 is back on the surface, immune microenvironment is positive, favorable. And on the top of it, if you put mycelic C, these cells are more likely to get killed. And since it's immunotherapy, the response rate is likely to be durable. But we don't have a long series. We don't have a large experience. So I can't share you the clinical experiences. But it is safe to give. And the recommended dose is give it every 15 days, not in between. And it can be given at the same time, not like a chemotherapy that you have to sequence before and after.
Okay, thank you.
Thank you. We had almost comment by Dr. Ayan Bhattacharya is there. Dr. Bhattacharya, do you want to comment? Your clinical use from your side?
Sir.
Hi.
Sir, am I audible?
Yes, you are.
Sir, most of my questions have very, very nice manner, and it is very informative also. The most likely thing, one question I have was I had what Dr. Dawar already put into us as its use with gemcitabine platinum combinations, whether it will be effective or not. I just want.
I'm losing you, doctor.
I think the network connection.
No issue. We'll come back to him in case if he's able to join.
Kumar, one question.
Yes,
question.
sir.
This mycelic then will be given as a maintenance therapy if we finish suppose 6 cycles.
Yeah.
Should we use it as a maintenance and how frequently and what then?
After chemotherapy cycles are over, Dr. Kamal.
Yeah, because squamous maybe we don't give maintenance. No.
So once the chemotherapy cycles are over, you can continue giving this every month till there is a response continues.
Okay. And weekly paclitaxel, there was a good question by Dr. Piyush.
Yeah.
Weekly paclitaxel chemotherapy, then we won't be able to give this drug. Or can we give it in between? Third day, we are able to give it, then every week we give paclitaxel.
So when you give weekly paclitaxel, it is a small metronomic dose. And it does not have a significant immune suppression. Actually, metronomic paclitaxel is known to stimulate immunity. So, as you mentioned, you can give in between the 2 cycles.
Okay.
So, on 3rd or 4th day.
Okay. So that is informative. So with this, we had a comment from all the users, and whatever we could understand that people are excited about how the data. How it looks like. Sure, people want more data about it, and also, Dr. Kumar elucidated many things about how to use it, when to use it. Those were very informative. One last comment from Mr. Rajiv, because there was a question regarding cost. Can you put what the approximate cost for this drug per month?
So, sir, we also have Dr. Krishna Prasad joining from Bangalore. If he also have something to it, how the cost of the therapy, sir, today it's available in PFS of 0.2 ml, and the cost is sticker price, which is MRP, is 4,900 rupees only, sir. And then every time you use first dose is 0.2 ml and then all 0.1, 0.1 only. So overall, the 4 cycle, 6 cycle dose is not crosses more than 35 to 40,000 rupees for the entire treatment. Versus, we all know how the treatment is.
So coming to Dr. Krishna Prasad, Dr. Krishna Prasad, any comment and any experience sharing from your side?
No, Kumar, no experience with this drug. And I think outside a clinical trial, it will be difficult to use this drug. So I would request you to initiate a investigator-initiated clinical study on this. I'm only worried that, this active immunotherapy has been tried even before and failed, probably because there is inability of vaccine-induced T-cell responses to overcome the tumoral mechanism of immune escape. So why this has, I see that this drug has been, approved and marketed since 2013. And there were other trials with other similar agents and most of them have failed. So I think to use this drug outside a clinical trial setting would be a little bit difficult. So I think with our numbers in India and especially in TMH, if you initiate a clinical trial and show reasonable efficacy, then I think it makes sense to start using this drug. Thank you.
Thank you, Dr. Krishna Prasad. So we heard all the comments from all the participants. Now back to Mr. Rajiv. So you had all the comments from people.
Yes, sir. And
people are think it is a promising data. Some people have used it. Some people are interested in. Some people want more data. So you have got all mix of things which you can munch upon. And back to you for the taking the proceeding further. Thank you.
Yes,
Dr.
sir. And Dr. Kumar, thank you. Thank you very much for the wonderful evening session. It is almost 1 hour and 40 minutes. And trust me, it's a wonderful way of discussing that. We are here to learn from all of you, sir, because you are the most learned medical oncologist India ever produced, and then you are expertise in your area. This product, as you said very rightly, been developed by in 2013, launched, and then working on the company. Dr. Hamar and Dr. Kumar, Dr. Vishwas said very rightly, very right perspective that they are there together from a long time and discussing this product. I'm sure Dr. Hamar would like to add a few points on it, because learning from each one of you, lastly comment from even Dr. Krishna Prasad that, yes, we are looking forward to generate Indian data, further addition on whatever we could do up till now on the investigative studies also trial. We happy to share with you, sir. We have a portal developed which is independent. It's an online portal wherein we can record data and we can help you with our medical team that, you putting up the data, uploading of data, understanding, which is uninterrupted data from the any person for any kind of, biases into it. So we are equipped with that kind of a facility available, sir. We'll reaching out to you on the specifically learning from you on this front. My endeavor is that I'm happy to really have doctors, such an eminent Dr. Advani gracing the event. Thank you very much, Dr. Advani, chairing the session today, along with Dr. Ashok Vaid coming and chairing the session today on this very platform, sir, and Dr. Shyam Agrawal. I mean, what more you want when such stalwarts are coming and joining this program and then gracing the occasion. Dr. Bowman coming in and asking about the question. Dr. Dattatreya coming in. Dr. Vamshi coming in and joining. Dr. Surendra Beniwal have shared his experience, more than 10 patients being already used. All the doctors are today coming in, and the way you have experienced joined, and then whatever we have. And of course, sir, Dr. Kumar, what you have used and then helping all of us organize this program. Thank you very much from Kedla Pharmaceutical, from my side as well. And I'm sure, sir, it is a promising molecule. I understand that it is developed by Indian company. I am very cognizant of fact, sir. Anything goes into NCCN or guideline coming into picture require at least $10 billion US kind of investment, and then clinical trial of of that magnitude. And of course, yes, we are Indian company trying to redevelop, and make sure that if the product is really having potential, why not to explore and understand it. So happy to hear comment from all of you, sir, and I will reach out to you individually. It's just a beginning, and whatever best possible assistance provided, sir, we will provide, and we'll make sure that the largely patient population which are not getting treated because of multiple reasons, at least start using, and then you generate your experience. We will be more than happy. I think Dr. Khamar would end this. We would be more than happy to generate data and publish it, sir. And we are looking forward extensively to generate data. In the end, I would, before I hand over to Dr. Khamar, I would like to thank him as well to taking time out, even the late evening hour from his busy schedule of manufacturing and researching and enlightening all of us. Thank you very much, Dr. Khamar and Dr. Amit Verma of taking medical proceedings further. To you, Dr. Khamar, and if you would like to conclude this session.
So as rightly mentioned, there were so many immunotherapies tried, tested and failed, and why this one is successful. So I'll just try to summarize that, why this has been successful. So first and foremost, for a cancer therapy, which I have not touched in my presentation, what you need is a Th1 type of a response, which is a T cells activation of a particular type, which is immunostimulant. It is known as a Th1. There is currently, as we speak, not a single product available in the world which will induce pure Th1 type of immune response systemically. There are products which are small molecules like imiquimod, which are known to produce pure Th1 response, but they are too toxic to be used systemically. So if you have seen it, Aldara is a brand name from 3M. It has to be applied topically, and it is used in basal cell carcinoma in one of the cancers. So the first and foremost is this is pure Th1 response enhancer. Some of you might have seen BCG being worked. BCG induces mixed response. In a small dose, it is a Th1 where it is not significant enough. In a dose which is used, whether it's given intradermally or intravasically, it induces initially a small amount of Th1 response, but is followed by Th2 response. So whatever gain you have made disappears. So that's the first and foremost. Second part is, as mentioned, this activates T cells. It induces cytotoxic T cells in the body, activates it. And cytotoxic T cells are necessary for killing of cancer cells, recognizing them as a foreign and killing them. That's the second part. Third part is, which we knew very late in the journey, that for any immunotherapy to work in cancer, cancer need to have two signals. All immunotherapies will provide one signal, but the other signal has to come. And to the best of our knowledge, MyCDXC has a desmocollin 3 as another signal. And if you have expression of desmocollin 3 on both the sides, then you get this response. And we have learned it hard way, because initially we tried this product in breast cancer where it failed miserably. We tried in a prostate cancer where it had a promising data in terms of reducing bone pain, but no advantage in mortality, no advantage in survival. So we have many failures which we are not discussing here, not presenting here. So it has not come out of a blue that we have this success. There were many failures prior to this. We are only presenting what was the success stories. So two important, Th1 response, and there has to be some specific receptor and ligand responsible, which has to come on both the sides, immune cells and tumor cells. And to best of our knowledge, this is desmocollin 3 for MyCDXC. So with that, I mean, as you gain more confidence, I mean, I'm always available. I'm always curious to find out how best this can do, what more we can do. So if there are any questions, queries, feel free to reach me out. I will spell out, or I'll put it on a chat box. My email address is B for Bombay, M for Mumbai, K for Kanpur, @Cadila, CADILA, pharma.co.in. Please feel free to get in touch with me. And Ghanshyam, I'm sorry, I've not seen you for a long.
So he just moved out because he had some program. He just told me that he just moved.
But thank you, everybody. And please feel free to reach out at least to me whenever you have a concern or a finding or some suggestion.
Yes, sir. Sure. Thank you. Thank you very much, Dr. Khamar. And before I formally conclude, I wish to thank our partner, Horizon, Mr. Tarun, who's helped us to organize this very program. Thank you very much, Tarun and Horizon entire team, which helped us to make the program. And thank you very much, all the doctors today gathered over here. I'm really, really glad to see all of you. I wish all of you remain healthy, hearty in these trying times. Be safe. Always wear whatever mask and all what we hear from all of you, sir. And we wish to see you always like these smiling faces, talking these science at this level. Thank you very much for joining us today.
Thank you, Raji, for your kind words. With your permission, we close the meeting. Thank you, everyone. Stay safe and good night.
Thank you. Thanks a lot. Have a nice time.
And we will certainly use it for our future communication. Please feel free to collect any queries given by the doctors and pass it to us. We will be surely answering everything. Thank you very much. Thanks once again. Bye-bye. Good night.
हाँ वैसे ही आदमी चाहेगा एक दिन और एक दिन